Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, your host for today. Our topic is the 2022 final rule, hot off the presses here, and its impact on MIPS, APMs, and the quality payment program. Our presenter, which I'll introduce in a moment here, is Dr. Dan Mingle, Executive Chairman. Many of you know his webinars well, and this one won't disappoint. If you want to go ahead and jump to the next slide, please. By way of introduction, for those of you who are new, here at Mingle Health, we seek to be your trusted partner in the transition to value-based care. We help you improve what matters, saving time, improving quality scores and outcomes, and increasing earnings. Since 2012, we've helped clinicians, group practices, healthcare systems succeed with the quality payment program. All of our solutions combine technology and advisory services to help organizations remove the burden of these programs and maximize your financial incentives, all while focusing on your patients and improving outcomes that matter to all of us. We do want to say a quick thank you to all the frontline healthcare workers who are continuing to respond to the global pandemic and doing all you can to keep all of us well, healthy, and productive. A few housekeeping items before we get started here. This webinar is being recorded. The slides and recording will be sent out later this week by email, so do keep an eye out. You can also download the slides right now from the handout section of GoToWebinar. Go ahead and take a moment to do that now if you'd like. We would encourage you to please ask questions throughout the webinar. We're going to keep track and answer as many as we can at the end, and also look for a couple of themes to highlight on our blog later this month from questions from all of you. We jumped past it really quickly, but I'd like to go ahead and introduce our presenter, Dr. Dan Mingle. He is Executive Chairman here and founder at Mingle Health. He's a family physician with private group and academic practice experience. His insights into the many problems that plague our healthcare system have led him on this quest to help practices and organizations of all sizes make sense of their data for value-based care success. And with that, over to you, Dan, and let's dive into the 2022 final rule.
Well, thank you, Charles. And let's see if everything comes up here.
You're coming through loud and clear.
There we go. All right. Well, welcome back. Thanks for coming today. Charles, you can cut your video, I think. And can you do that on your platform? All right. Not that we don't enjoy seeing you, but let's not crowd the slides too much. So this is an interesting year. Very interesting rule. Partly for what's in it for this year, but also it's marking some interesting mileposts in the program. We've been in transitional MIPS since the beginning. There's some phase-in rules that were enhanced over other legislation since, all leading to what Medicare is now calling traditional MIPS. And we really enter traditional MIPS in another year. Transitional MIPS ends in 2022, going into traditional MIPS. And in this rule, Medicare even plots a course beyond that, predicting an end to traditional MIPS and the beginning of what I'm calling MIPS version 2, or they're calling new MIPS, which perhaps will begin in the year 2027 and based on the measure of the MIPS value pathways. A little bit more of this later. And part of that whole transition web interface is now scheduled to ends for MIPS groups after this coming year. So you can submit your 2022 performance in the web interface, but beyond that, you have to choose one of the other methods. For ACOs, they have a little longer to transition. 3 more years until you have to be off web interface entirely. And in MIPS version 2, mandatory subgroup reporting of MIPS value pathways is intended to be the foundation, with each MVP containing a cost measure. And they also plan to move to, between now and then, to fully digital measures, which is one of the reasons they're getting rid of Web Interface, which is pretty much the sole surviving manual method. Pretty much, there's some exceptions to that, but we won't get into that detail. And MVPs are ready to roll, but put off another year, 2023. The MVPs are scheduled to start. So I'm going to review some of the the final rule, some of the new persisting COVID adjustments, the future of the QPP, MIPS basics, alternative payment models, APM. Oh, you can read that. I'll move on to our next slide if I can get this thing to follow my instructions. All right, here we go. Now, on this page, and get this from the slide deck, which you'll have access to, there are some important links. If you want to access the 2,400 pages of the final rule, they're at that top link. If Medicare has published some pretty good resources attaching to it, listed here, available on the qpp.cms.gov website at this link, and these are the four documents you'll find inside that. They're a little redundant, but they've got some good links into it to some of the core data and lists, and it's relatively clearly, not as clearly as I'll give it to you, but relatively clearly outlined. And of course, this webinar, a link to this webinar recorded and a copy of the slides will be distributed and is available at the same link at which you registered for this. Participation has been high. I think these numbers include some estimates that include the people who took the exceptions for the PHE. So inflated a little bit, but the numbers are pretty much been right to the top since Medicare instituted the low volume threshold. Still very high positive payment rate, 90.6% got a positive adjustment in 2020. And again, a large number of 933,547 who reported at least one measure activity, and at the bottom of the columns there, the numbers that took the EUC for COVID-19, which is a small but significant proportion. There we go. COVID. Interesting, just hot off the press on the 10th, that's last week, Medicare announced already, last two times they put the emergency or the automatic extreme and uncontrollable circumstances policy into effect. They announced it for the last 2 years in the midst of the submission season. They just announced it last week that they will do it again. So people who do not make a submission will not get a negative score. They'll get the automatic extreme and uncontrollable circumstances policy. We are still in that PHE, the public health emergency. The PHE related rules are still in effect, and Medicare plans to keep in effect until the end of the year following the end of the emergency. So they're already saying it's going to go to the end of 2023. Expecting it to last at least through this January, and we'll wait for the next final rule to see if it extends yet another year. Interesting, they realize there's an error in the automatic EUC, or at least an unintended consequence, that for this past year, 2020, a lot of the EUC automatically provides to individuals, which is the default assumed submission. And when individuals were counting on that to be excused, and groups made made a submission that included them. It gave them some unexpected penalties. So they've reopened the EUC application window for last year. So you already know your scores, but if it wasn't what you expected it to be, and you think COVID affected that, you can still put in an EUC application for last year. Find the link on the QPP website. It's open until the end of this month. And don't use the EUC application, which is applicable just to the year we're in, but ask for a targeted review if you want to take advantage of that. There was enough data submitted in 2020 to do the benchmark, so they're not going to have a workaround for 2022 data, for this coming year's data. The benchmarks that they'll publish sometime before the end of the year should be adequate for next year. There was a proposed COVID-19 immunization measure that has been postponed, mostly because of all the noise about the protocols and all that. So we expect it ultimately to be a long-term measure similar to the flu shot measure and the Pneumovax measure that will have that option. And all the improvement activity that is reporting COVID data for research has been extended because of the continuing PHE. A little bit more on those future trends. MIPS participants will continue to receive a payment adjustment based on the weighted total score. Qualified APM participants, here's another example of the changeover from transitional to traditional MIPS. They will get a 5% incentive bonus payment for one more year of performance through the payment year 2024. After that, starting in payment year 2026, there will be a higher payment through the physician fee schedule. So that's coming. Let's see, we've covered a lot of this already. The MIPS value pathways. Again, the foundation for new MIPS will be the MIPS value pathways. We expect they'll come live 2023. Initially, you'll have the option. You will even be able to submit the MIPS value pathway as a large group. So just like you get credit for a 6 measure set that covers the whole group, you can use one of the 4 measure MVPs to cover your whole group for those early years of the MVPs. They expect, starting in 2026, to make subgroup reporting in MVPs mandatory. So interesting time when your groups who have been able to make a 6 measure submission to qualify the group, the 4 measure submission will apply to every valid subgrouping that will have to be made. So you'll have to break those large multi-specialty groups and academic medical centers into specialty subgroups and submit a 4 measure set for each. So very interesting time. It might be worthwhile to start familiarizing yourself with those MVPs in another year when they come out. You can expect increasing attention to health disparities and being built into measure stratification, maybe some dedicated measures. You'll see more in improvement activities. And you'll expect to see fully digital quality measures. Perhaps, I think it's a little aggressive to think they'll achieve it by 2025, but perhaps it'll be here. So for eligibility, we've added the final credentials that can bill Medicare that haven't yet been included. So in 2022, we're adding certified nurse midwives and clinical social workers. There is a new measure set for clinical social workers, a specialty measure set, and they'll get automatic reweighting of PI, of the promoting interoperability, and everyone else still is unchanged. In the scoring last year, that is the 2020 performance year, we hit the plus or minus 9% adjustment expectations, and that's where we expect it to stay permanently. And I would be surprised if it changes when we go into new MIPS in another 5 years or so. And the performance category weights, they've likewise, in this coming year, they'll hit their cruising altitude. So quality and cost worth 30% each, promoting interoperability at 25%, and improvement activities at 15%. The bar charts show you how it's changed over the years, building up to this year. And again, we expect to sail on at these levels, and I would expect it again to go into new MIPS in another 5 years or so. Don't look deeply at this table. I just want you familiar with its size, shape, availability. If you qualify for reweighting for any reason, automatically or by application, this shows under all the possible combinations how your scores get weighted. And interesting, this year they've now broken it into two charts, one for most of our participants and one for small groups, with a couple minor variations in the numbers. So again, look for the right chart if you need it, planning your reweighting. Performance thresholds, that's the score at which the score crosses the zero axis, the zero line, for adjustment. So at that score, at that threshold, there is no adjustment, positive or negative. Above the performance threshold, again, everyone gets a positive adjustment, below negative. And the additional performance threshold, that's the number at which you start sharing in the 500 million that Medicare has kicked in as an exceptional performance bonus for the highest performers. And this, for the 2022 year, it's now set, well, the parameters have a loose setting. Again, we're at the permanent rules. Secretary of Health and Human Services still has some leeway for, but it's narrowed. It has to be based on a previous year's scores and can be either the mean or the median of those scores. They've chosen, because it's the most favorable level for you, chosen the 2017 numbers to compare against. So and they've chosen the mean for that. So the performance threshold is, for 2022, is 75, and the additional performance threshold is 89. Now, interesting note on the additional performance threshold, that exceptional performance bonus goes away after next year. So it's the last time you'll see it. That has been the source of the majority of the incentives that have been distributed since the start of the program. So without it, you're going to depend on distributing losses of those below the performance threshold to fund any gains for those above. And I think many of the dynamics will still soften that there's not going to be a lot of losses, so there's not going to be a lot of gains, but we can expect over a couple more years as these transitional, the effect of these transitional rules disappears, we're going to see more striation of the comparison. We'll have more people on the negative side, a broader range of scores. Here's the Medicare publishes a sample graph, or it used to actually look like a prediction or act like a prediction. They're abandoning that now, saying it's just an illustrative example of how the year could look. But you can see the performance threshold at 75 and the additional performance threshold at 86, and how it relates to your adjustment factor over to the left on the vertical axis as you progress. And again, recognizing that after that exceptional performance bonus goes away, this line above the above 75 will be a straight line to the right border. And all the numbers compared year to year are in the chart to the left, and you can see how we've just been building up to this crescendo. They've adjusted the final score hierarchy for how you get assigned a score if there's multiple scores. and they've just added that subgroup final score to it. Essentially, if you're participating in a virtual group, you get the virtual group scores, period. Anything else, they will assign backwards to any score that you submit or is submitted on your behalf. It will assign backwards to the individual, and then you'll get the best of those individual scores that apply to you. There's more protection of small practices. Analysis of the data still shows that they seem to be working with a resource-related penalty to start with, or barriers to begin with. And most are not taking advantage of the reweighting of promoting operability they've offered to small practices. So they're going to do that that reweighting of promoting operability, interoperability, automatically. And they're applying the different reweighting hierarchies. Small practices, individuals in small practices and those small practices can still make claims submissions, although they're changing that a little bit. They found some unintended consequences. They were calculating both the individual and group scores automatically and giving you the best, but they found some people falling through the cracks and not getting the right score with that. So they're you have to now make a request to make a group submission, and you make a request by making any kind of a group submission. You submit your improvement activities as a group, you submit your promoting interoperability activities as scores as a group, and if you do, then they'll calculate the claims based measures as a group. Otherwise, it applies to the individual. Small practice bonus continues, and the 3-point floor on the class 2 and 3 measures continues for small practices. Bonuses, another sign that the transition is ending. After this current performance year, the bonus for extra high priority measures goes away, and as does the end-to-end electronic reporting bonus goes away. After this coming year, as I said, the exceptional performance bonus goes away. There are several bonuses that will continue: the small practice bonus, the quality improvement bonus. So if your scores in 1 year are better than the year prior, you get a bonus for that. The assumption is if your prior year score was below 30, they adjust the number up to 30 and compare it to that 30-point floor. Complex patient bonus continues. It's not necessarily permanent. If Medicare ever becomes satisfied with the complex, with risk adjusting the measure scores, this will go away. But right now, it's they've made permanent or semi-permanent the 10 points. They multiplied the 5-point bonus by 2 because of COVID related dynamics, and are planning to continue that for the moment. But they've broken it into 2 scores instead of combining it into 1. Now it's 5 points for medical complexity based on HCC scoring, and 5 points for social complexity, represented by proportion of dual eligible patients in your practice. They put a 10-point cap on the combination, and they've also eliminated any practice who falls below the mean on each of those scores. So only when you hit the mean or above do you get a bonus. So the lower end is capped. They found the analysis of the data showed there was little difference in the scoring, or no significant difference in the scoring related to risk level if you were in the lower end of the scale. If you're above the average, then they started breaking out, and people with a higher proportion of more complex patients weren't able to score as well. Okay, on the quality performance category, biggest news there is sunset of that web interface for MIPS groups after this coming year. So if you've been depending on that, you're going to have to choose one of the other measures after 2022. You may make your choice for 2022. I'm not going to get into the details of that. We're having a webinar tomorrow to focus on the end of the web interface and to make the transition to digital clinical quality measures. So you can register at this link should you be interested in joining us. Data completeness for 2022. They threatened in the proposed rule to make it 80%, but decided to hold it at 70, not only for this year, but the following year. So that's set in the rules at 70% for these next 2 years. That's, of course, of your eligible instances for each measure, you have to submit at least 70% of the eligible instances for all patients and all payers, with the exceptions of Medicare Part B or claim submissions is only pertinent to Medicare Part B patients, still the 70%, but Medicare Part B. And web interface, the sampling that you have to submit is only from Medicare Part B patients as well, and you need to submit 100% of those 248 patients. The measure inventory changes as usual. There's one new ECQM, 2 new MIPScqms, 1 new administrative claims measure, which is hospital admission rates for patients with multiple chronic conditions. They're removing a duplicative measure for 4 that are unaligned with Meaningful Measures Initiative, 5 whose stewards gave up on them, 3 that are topped out. And they removed the option for claim submissions for 2 measures. There's substantive changes for 87. So as usual, my advice is be sure you review the specifications or work with if you're engaged with us, work with your consultant to be sure there's you're recording everything you need to score well, continue your performance in your measures. Don't count on your measure being repeated for a year. Make sure it's not one of the ones that's been discontinued. Don't count on the specifications being the same. Be sure you've checked that out. And we talked about the COVID vaccine measure being postponed. Let's see if I can make this advance go. There we go. Measure types, I think this is always a little confusing, but they've made it more confusing. There were class 1, 2, and 3 measures. Now there's a class 4A and 4B. Those are new measures. So new measures, when they meet data completeness, have a performance year benchmark, and meet case minimums, you'll get a 7-point floor for those in their first year and a 5-point floor for those in the second year, and they'll all deliver points up to the maximum of 10. If they don't, if they don't have a benchmark, or you submit it and you don't have the case minimum, then you just get the 7-point or 5-point floor depending on the year. In the other measures, we expect in the class 1, which is all in. It's an established measure. It has a benchmark. It meets the minimums. It meets the data completeness. There's still for 2022 a 3-point floor on that. You'll get at least 3 points, but the following year we spread those scores out. 2023, you can get the minimum of 1 point to the maximum of 10. And class 2 measures, you still get a 3-point minimum on those for 2022, but then that goes away in 2023. And the class 3 measures, if a small practice submits at least 1 patient for any measure, they get the 3-point floor on that. And that's already gone to 0 for everybody else. ACOs or CAPS, the survey measure, it's now converged onto a single measure, no longer divided between ACOs and MIPS. They differed in how eligible patients were assigned, were selected. They differed in how the score was calculated and contributed to the final score. But the measures have always been the same. Now all those are merged into one that's called CAPS for MIPS. Unplanned admissions for multiple chronic conditions. I'm not sure we've seen much of this, but they've had a version for ACOs and they've had a version for MIPS, and now that likewise is collapsed into a single version called MCC for MIPS. And that combined measure is live in the APP and MIPS in this coming year. It applies in MIPS for groups of 15 or more, or groups bigger, not small practices. Everybody else, it applies if there's an 18 case minimum to calculate data on. All right, moving on to the cost performance category. CMS has built in some flexibility to suppress cost measures after all the data is in. They've done all the calculations. If they find some statistic anomalies that doesn't appear to be reliable, even up to the time that the feedback reports are distributed, they can suppress those measures. They've also announced a new mechanism to get stakeholders to create cost measures. So if you're interested in doing that, look for the guidelines in qpp.gov. It'll help you, or qpp.cms.gov, to help you know how to get involved in cost measure creation. There are 25 active cost measures live for 2022, which includes 5 new measures. I'll list on the next page, next slide. CMS, of course, calculates all those measures. You don't do anything. You just get any measure for which you have sufficient cases will be calculated on your behalf. And each and every one of those. There's a few specifications, like I think in the total cost per patient, the TPCC measure, there's now some specialty specifications. Here are the new cost measures: melanoma resection, colon and rectal resection, sepsis, diabetes, and 2 new chronic condition measures. We haven't seen one of these before. We will see more. Diabetes and COPD are each newly to the list. And we are going to see with MVP creation, there should be at least one, possibly more cost measures related to each MVP. They may be already in the selections, but notice not many of them match the MVPs at this point, so you may be seeing a lot more newly created cost measures for those MVPs. Promoting interoperability, use of your EMR. Here's the new scoring sheet for that. E-prescribing still worth 10 points with the same exceptions. A query of PDMP, the state Controlled Substance Registry, still a bonus by attestation. Health information exchange hasn't changed. In fact, patients' access to their health information hasn't changed. They did not take the proposal changes in that because of some uncertainty about the capabilities. They've changed the public health and clinical data exchange measure, now making immunization registry reporting and electronic case reporting mandatory. The others, any one or more of them, worth 5 bonus points, but those first 2 mandatory. Now you can qualify for an exclusion, that is, if you don't give immunizations, you don't take care of any patients who would need case reporting. There's others, so look at that exclusion list. It's not real hard to get on to be able to attest yes. It's either live and functioning, or you're in the queue, you've registered, you're in the queue waiting for it to be implemented. If you say yes to both of those, you get that score. If you say yes to one and exclude for the other, you get the score. If you exclude for both, those points get reweighted. And if either of them is a no or unreported, you don't get any points for the category. They've also simplified the information blocking attestation. There are 3 statements you had to make before. Medicare has determined that ONC is now monitoring, doing a lot of monitoring, and the rules include some civil and monetary penalties. So they thought their engagement here was redundant. So there's only a single attestation that you don't do anything to block data access. Here are the SAFER guides, which is the new measure. There's 9 of them, and we're required to look at to review the high priority practices every year. It's basically a checklist to remind you of what's best practices with information handling. Action is not required on any of those, but your review is interesting, and at least the first year that this is live, your a yes or a no answer, I did it or I didn't do it, passes you on that. I don't think it'll stay that way. And a reminder that there really a lot of promoting interoperability is required, is all or none. If you miss any of these 7 elements, you don't get any score for promoting interoperability. So that's e-prescribing, health information exchange. Oh, you can read the list. So improvement activities, 7 new activities in the inventory. 3 are related to health equity. 6 activities have been removed, 15 modified. They've expanded the criteria for nominating activities in an effort to make to get down to a more actionable set of nominations. And they've expanded their own freedom to suspend an activity during a performance period if the evidence behind it is changes. Predominantly, there may be other reasons. And they've clarified that when we go to subgroup reporting, the subgroup 50% of the subgroup will have to participate in that activity in the year, each for at least 3 months, very identical to what the whole group rules are now, but just clarifying what will happen when we move to subgroups. I haven't listed these as usual. I know most of us try to repeat our improvement activities year by year. Make sure your activity is still live. Make sure the specifications haven't changed significantly so that you know that you are still eligible if you're counting on that measure. Feedback and compare, just a reminder that they are required to give you feedback once a year. Their intention is that it come out at or near July 1st, and they've generally been successful with that, except for COVID years in which they've had delays, distributing August 5th last year, and this year, the 2020 data came out in 2 tranches, August 2nd and September 27th. And of course, that's not closed because you still have an opportunity to submit for a COVID hardship exemption for last year. Of course, a big part of this is Medicare's desire to put data out there to help patients choose doctors. We used to know this as physician compare, and hospital compare. Those sites have been combined and rebranded. It's now all called Care Compare. It includes all these other categories. Everyone they're collecting value data on, and they're creating some new links between them to understand as you click on a provider or a group, what groups those providers belong to, what affiliations they have with these other organizations. So expect that to continue to expand. They've confirmed that they will be including MVP data in that, giving a year. The first year of MVP data won't be included, but following that, expected to be included in this. Just hot off this press, yesterday, Medicare announced that the data from 2020 is now ready to be posted, and it's available for your preview. Law requires them to give you a preview period before it's published. So their QPP website will give you access or instructions how to access that and review your data. All right, a little bit about the alternate payment models. Again, the biggest news for alternative payment models is that the web interface is sunsetting, phasing out between 2021 and 2024. The APP that's replacing the program for APMs, or for MSSP at least in the past, is live already. So if you're an ACO, if you're an MSSP, a Medicare Shared Savings Plan, you are already using the APP, which includes you don't have to, all APMs at the moment have a full score for improvement activities. You still have to do your promoting interoperability measures. That's typically done as a group, and the rules for how they come together are in this program. Cost measures, well, you don't have cost measures because it's built into your shared savings. So it's essentially the rules about constructing these and the quality measures. Now you still have the opportunity to use web interface for the next couple of years, but there is a big incentive for using the three measures of the APP, and that lowest major bullet, it's the quality standard. By meeting the quality standard, every year, you qualify yourself to share maximally in the shared savings and to avoid the deepest shared losses. And if you don't get the standards, if you don't meet the quality standard, then you get the full share in the full loss, and you can't share in the savings. So the change there is that users of the 10 web interface measures have to hit the 35th percentile on each of the 9 of those 10 measures that are scored to hit that quality standard. For 2 years, for your 3 measures, one of them, an outcomes measure, has to be at least at the 10th percentile, and one other has to be at the 30th percentile or above. So if you hit those, you've hit your quality standard and share fully. Medicare predicts that over the next few years, from the trends, from the current scores, and when in the next year where the quality standard goes up to the 40th percentile, that as many as 40% of ACOs will not meet the quality standard. So it's important to get to work on that. And again, to get the details of this, join us in the webinar tomorrow. The one other thing I want to say about this today is that I'm worried about that switchover for you from the web interface to the APP. There's a lot of misinformation, a lot of confusion out there. There is a relatively easy way to succeed in that, but I don't think you're being guided in that way by those who should be able to do that for you. Even Medicare, when Medicare is talking about the details of the rules, they always talk about MIPS, CQMs, and ECQMs as being a sort, that's on the second minor bullet under quality submission. But when they're talking about it in webinars and in other texts, I'm just seeing them talk about ECQMs, and a lot of discussion that I agree completely with, that ECQMs are a hard path to follow. It expects EMRs to cooperate with each other, and an ACO the typical ACO has more than 15 EHRs in the group. It's nearly impossible to see those as coming together, or if it does come together, that it's affordable and sustainable. It just seems to be something that will break apart. Whereas registry, we've been doing this for 10 years. We always bring data together from all EHRs. We normalize into the database and can take any selection of those and combine them into a single, cohesive, accurate submission at no higher cost than what we've always done, and with the same rapid turnaround time. So I think those who are taking that extra time to try to build the ECQM process are bound for some heartache. And those of you who go the registry route, particularly tried and true, we've been doing it. I think you'll have an easier time of that. I suggest you prove that before it becomes too late to, well, if you had to do the EHR route, it's going to be long and expensive. Primary care first, one of my favorite APMs. Of course, family physicians, so why not? The first cohort began in January of this year. The second cohort has been selected. They're in contract and will begin January of next year. Big issue though with the selection. Medicare used COVID year data for attribution for this second cohort. So a lot of people didn't seek primary care during the pandemic. So attribution numbers are really low, which means payment is based on those attribution numbers, and therefore the payment going into the program is projected to be very low. We've had a lot of success building that attribution. Also building the HCC risk optimization, which is the second factor in the amount of your quarterly payment from Medicare. So engage. You'll be disappointed with the numbers Medicare gave you. Engage with us. We'll help you bring those back to where they should be, and get to give you a big improvement in your payout. It's the only way to make that program successful. So please don't accept those low numbers. Other APM changes, there's new codes in the list of primary care service codes. I'm not listing those, but the list is available. They're relaxing the repayment mechanism requirements because almost nobody uses those requirements to make their repayments. They're giving existing MSSP participants the opportunity to reduce their repayment mechanisms. They're streamlining the application process for MSSPs, and they're also relaxing some of the beneficiary notification requirements. They're also extending the threshold score a little bit because they put growth in the program on hold through at least one or two COVID years. So this is a new, just be aware that there's a new schedule for advancing that QP and partial QP threshold for the Medicare only or the all payer combination models. And we're just about to the end here. MVPs, again, just a reminder that they're coming in 2023. I don't plan to get it. It's a complex program. A lot of the rule deals with that. And I felt since it's still another year away, we should focus on this on a mid-year, sometime in the next year, well in advance of it going live. We'll have a dedicated webinar on that. So that's That brings us to the end, and thank you very much for your patience. We're open for questions. Charles, do you have anything to toss my way?
All right, thank you for that dive through the 2,400 pages. We've got a few questions here. First of all, from Jessica, could you talk a little bit more about measures with substantive changes? So I think you have probably had a slide a little bit in the quality measure section that highlighted some of that. In particular, is it considered that no benchmark for measure, go ahead.
Oh, go ahead, finish so I can be sure I'm
No, for measures like number 337 or 176, is it considered that there's no benchmark and that are they still worth 3 points for small practices?
All right, this seems to be a combination of two questions. The substantive changes is really about the specifications. That is, when they've changed the eligibility requirements, that is what CPT or ICD-10 codes you need to qualify for the measure, or what events, what sequence of events has to occur. That's considered, or the performance requirements and recording requirements hit the numerator. Those are substantive changes. So check the rules for your measure. Typically, every year every year they do. It's not typically. Every year they've given a document that goes measure that outlines the measures that have changed and how and why. It covers a lot of tedious changes, but that's the best place to find those changes. About the class measures, that's except for the, well, no, I was going to say that's been stable for years, but they have been fooling with who qualifies for the floor, and then the addition of new measures to that. But key to that is the existence of a benchmark. So if there is a benchmark, and it's an old measure, and you get the case minimum and the data completeness spec, that's a class 1 measure. If it doesn't have a benchmark, then it drops to a class 3 measure, and Medicare will benchmark it during the performance year if they have enough data. So you'll go in not knowing what your score will be, but then there'll be a benchmark to score it against, and you'll get a score for it from that year. They will look back an extra year to get a benchmark if it's available, and then if there's nothing, then it becomes that a class 3 measure.
Okay, measure specifications. Let us know on our website. We have live chat, so if you go out and look at that and still have questions, feel free to get in touch with us. Our next question is from Danielle. Can you explain data completeness? Is it 70% of the denominator, numerator? CMS says if reporting CQM or ECQM, we need a specific amount of data.
Yes. So the denominator is the patients in your practice who are eligible, or the events that are eligible for reporting. It could be at a patient level, it could be a patient encounter level. So each encounter needs to be reported. So we call that an eligible instance, an eligible patient, an eligible encounter. You have to have an accurate number in your denominator. Everything else flows from that. And then in the numerator, you have to determine whether your patients have performance met, performance not met, or they have some exclusion. And you have to know those scores, know those statuses on 70%. If you can't find the data on 30%, if it's in paper charts, if 70% of your data is in the EMR and you have it, and you couldn't or didn't abstract it from the paper charts, you can exclude, you can miss at least, or you can miss no more than 30% of your denominator. Now, if you get all your data from the EMR, Medicare assumes it to be complete, 100%. If you get your data from secondary sources, then you have to explicitly see the criteria for met or not met to be able to report it, and that has to be 70%.
All right, well, thank you for your question, Danielle. Our next question is from Mindy. This is related to promoting interoperability and case reporting. What if our state registry doesn't accept reporting from our offices? They only accept hospitals. Do we get credit for our intent to provide case reporting when the state doesn't accept it?
Now, I recommend you just review those exclusion requirements, or bring it to our chat or your consultant. But I would expect that to be a valid exclusion if you're.
Yes. Yeah, absolutely. Our colleague who looks at the PI category in particular said that there is it likely could be exclusion number 3. Operates in a jurisdiction where no public health agency has declared readiness to receive electronic case reporting data as of 6 months prior to the start of the performance period. Well, that's a mouthful, but it does sound like, as Dr. Mingle said, that there's likely an exclusion there for you to apply for. Thank you for that question, Mindy. Our next question is from just pulling it up here. It's lost in my list. Can you talk about, this is from Rebecca, can you talk about the transition from MIPS to MIPS version 2 and the impact of the requirements for ACOs or different types of measures, considering the longer term goal of being fully digital?
A little bit complicated in that answer. Well, one, really the only manual method in significance that's hanging on there is web interface. When web interface goes away, we're pretty much where Medicare wants to be with fully digital measures, although there's other changes to the infrastructure, which again I'd classify a bit as pipe dreams. But I would, in the current rendition, and you'll get plenty of warning when that rendition changes, the MVPs are going to be based on on 3 types of submissions. They will offer several administrative claims measures. So you can just say, Medicare, please calculate this for me, and they'll do it from the data they hold. We've seen those off and on in the years, and all cost measures are administrative claims measures. They're things they can reliably measure from the claims. And other measures that you need to submit, you can either submit as an ECQM or as a MIPScqm. And that those divisions might blur and change a little bit over the years, but you'll get have a registry or be a registry to submit those, or engage an ECQM provider. EHRs, when EHRs provide automated measurement and submission, that's an ECQM. And there's vendors that also do ECQMs. Connect to your EHR, get the data, and send it. MIPScqms are very similar. Frankly, MIPScqms through registries have more flexibility. They still go after the data in your EHR. They can have they can cast a broad net for differences in your documentation standards, but you can count on the MVPs to to be within those three categories: administrative claims, electronic clinical quality measures measured by the certified software, and MIPScqms, which is external to, but still able to look into your electronic data and calculate those measures.
All right, well, thank you for that question. If you have a follow-up, feel free to let us know. And we've done it. We've reached the top of the hour here. We've answered most of the questions, so thank you so much for sending in those thoughtful questions and for hanging out with us for this entire hour and all the details of the final rule. And thank you, Dr. Mingle, for sharing your wisdom with us. Just a reminder that the slides and recording will be sent out later this week by email, so keep an eye out for that. And do join us for our web interface transition webinar tomorrow. And be on the lookout for future topics like diving into the MIPS value pathways. Thank you so much, everyone. Have a wonderful day.
Thank you, everybody.